Hey, it's Monday afternoon, and you're here with Joe Lamb and Michael Stone. How are you today, Dr. Stone?
I'm doing just fine, Dr. Lamb. How about yourself?
I am good,
Happy
thank you.
afternoon coffee break.
I've got English breakfast.
We were talking.
I'm out of sync.
You have English breakfast tea. That's outstanding. I love tea. We were chatting a little bit earlier, and we were both kind of contemplating hesitancy, and some of the hesitancy around things that are new, or hesitancy around taking part in public health measures. And we were chatting a little bit about how do you deal with the hesitancy of 40% of the military members refusing the COVID-19 vaccine, or in some surveys up to 60% of people with evangelical belief, or depending on the political party, as low as 8% hesitancy in some corners, and as much as 40 to 60% hesitancy in other corners, and how the hesitancy to embrace a public health measure will end up affecting herd immunity, and will impact whether we have a longer tail of this pandemic or not. And you and I were chatting a little bit about the components that you need to have to overcome hesitancy or to embrace something new. And you were talking about trust.
Yeah, I think that's a big part of it. I think trust is not something we give easily. Trust is not something that we give easily. And when we do it, when we are willing to give it, the question becomes one of, are we giving it to the right people? And at what level does suspicion and fear keep us from giving trust and lead us down the path to not doing what's best for us?
Yeah, interesting. I think you're onto something there. I think there are multiple levels of trust, and trust in the face of uncertainty. And at different times in our history, well, in this country for sure, when trust isn't attained, then there's significant pushback. And I think that plays out in all aspects of life, right? Whether it's uniqueness of bigotry, whether there's a uniqueness of trust issues in different school systems, in different grocery stores, in different medical practices, in different neighborhoods. It is a challenging nut to crack on how we build trust. And maybe first thing is communication and conversation.
Yeah. Well, one of the novel things about, just reduce it to something very concrete, like the health practice of, will I be vaccinated or not? One of the things is, this is truly the COVID-19 vaccine is truly a novel situation, because I can't think of another drug or vaccine that's been given an emergency use authorization at any point in my lifetime. And so we have a vaccine which we're asking all Americans to take, which has not yet received FDA approval. And instead, based upon short-term data, we have a recommendation that short-term data, the risk benefit seems to be such that we're going to give it an emergency use authorization. And so it's kind of like, it's not a resounding yes that this is good for you. It's like, yeah, we think it's good for you. And that comes in the setting of all the mistrust around vaccines and vaccine campaigns in, the last number of years. Parents concerned about the risk for autism, people concerned about the risks that have been associated with the HPV vaccine, for example. And it's led people to be a little hesitant as they jump in.
No, that's exactly true. And we've seen it for, a couple decades. And part of that hesitancy, I think, is partly around messaging that there are no adverse side effects when we know that there are adverse side effects, but it's a relative risk. And so I can appreciate when the languaging is so black and white that there's no adverse side effects, and then the perspective of what is adverse to a public health statistician or data collector is different than what the definition of an adverse side effect is to the receiver. And I think that we have a languaging and communication challenges on many different steps, many different places in that whole continuum.
Yeah, and I think it's because there's also someone else in the middle there, between that scientist who's looking at the vaccine data, between the principal investigator who's doing the clinical trial. And, obviously, if they're dedicating their lives to that sort of research, there is a little bit of a confirmational bias that they're going in with that, they tend to be in the pro-vaccine camp to begin with. But there suddenly is someone in the middle, the politician or the policymaker, who is going to take that scientific information and decide how it's going to be packaged and shared with all of us, and decide, whether misinformation serves their purpose more than true information does. And unfortunately, for the COVID vaccine, we have the misinformation around prior vaccines, but we have all the misinformation around the use of masks. Well, you should wear a mask to protect others. It doesn't really protect yourself. Oh, well, we now have some extra masks. You should wear them to protect yourself. The data, the messaging changed while the data didn't change much. And I think, I think any suggestion by anyone, whether it goes from, I guess it was Wakefield, right? Wakefield, who wrote Callous Disregard, whether it goes from Wakefield in England and talking about, mumps, measles, and rubella vaccinations, right on through people without data. The American Council on Immunization Practices and the CDC and the FDA hasn't wanted to hear the criticism. They haven't wanted to hear the anecdotes that practitioners have said, and they hide behind the double-blind placebo-controlled trial.
No, that is the challenge, isn't it? For all of us who've been out there in in practice and in communities and in families. And I think that we also, much of our life is driven by headline, which is a soundbite, which is not the complete conversation, the nuanced conversation, the nuanced appreciation for some of the shared misinformation or shared exaggeration that ends up becoming the norm. And so, much of this pandemic has been news release information, where science is not always completely, well, it's not always opaque, let alone completely clear. And and it's coming so quickly. So for example, yesterday I just plugged in COVID-19 to PubMed, and there were over 134,000 articles in 15 months.
Yeah.
That is remarkable, let alone how do we sift? How do we pause and consider? How do we take into account? How do you take into account? I mean, it becomes a very personal question. So I understand hesitancy, and I understand also that everyone has a different level of information that is adequate to make a decision. And other people, and I also appreciate that some people will just, I won't say hide behind, but are willing to just put up the statement that it's way too early, which I also appreciate. Challenge.
I mean, for me,
with that, so
yeah, for me, a big part of this problem is how we look at data. We have this hierarchy of evidence, right? And we say double-blind placebo-controlled trials are best for determining treatments. And it is clearly an excellent way of collecting data on what works for groups. And, I see this a lot of the time. One of the big errors of judgment that I see coming out of clinical trial use is that someone will pick some variable, and we see this among our colleagues. Some study will show that some cytokine like NF-kappa B changed dramatically between the two groups, or you compare one group to the other and they're statistically different. But the variability is so high for the individual that you can't use it diagnostically or even prognostically or even as treatment. Did it get better with treatment? And yet we have colleagues who do that all the time, because what they don't realize is that what happened to a group of people doesn't say what happens to the individual. And double-blind placebo-controlled trials are great at showing the groups. And particularly if the trial's big enough, people who are unique, who differ in some definable fashion from the other people in the group, get lost in the noise. If you have 100,000 people in a study and you have some sort of selection bias, you may not get equal representation between the two groups of 50,000. And if it's a rare event, that rare event may end up looking like it happens with no difference between the two groups. The frequency is the same between the two groups. But if you backed up and said, what if we take a group of children who have had an office visit for questions related to, are they on track for developmental developmental guidelines? And what if we also select further down a little bit and say, you know, they have challenges with their methylation in terms of their homocysteine cycle and how well they methylate and how well they use folate. Well, in animal studies, thimerosal was shown to lead to a 50% reduction in the activity in rats of methionine synthetase. So, if you start with a population of people with a unique challenge who may not be represented well in the study or may actually have been biased in the study, like you can imagine that anybody who has concerns about their child probably isn't going to enroll them in a vaccination study. So,
Right.
So you have a bias of leaving out the at-risk person. And, if we identified this group and we did the kind of study that would say, hey, we actually found that in children with developmental delays, certain genetic SNPs and certain vitamin deficiencies, that vaccination is a mistake, maybe you'd identify 1 or 2% of the population for whom vaccines are a bad idea. And if we did that, we wouldn't hurt herd immunity because we could still be, 98% of us would be safe to take the vaccine and it would be enough to have herd immunity and we wouldn't hurt the other children. But what the position that's been taken is the vaccines hurt no one. We see anecdotes and hear reports that they do, and we create a lot of moms and dads who appropriately are concerned, and physicians who are concerned about vaccinating certain populations of children, and then toss on that the misinformation and the lies that came out of Trump's administration and that smirky smile on Fauci's face when he gives partial truths or smirks about not knowing answers. Combine that with changing healthcare policies in the last year and an emergency use authorization for a new vaccine. And it's not surprising that people aren't going all in for it.
So that brings it down to the conversations we have in the clinic and risk assessing, helping people risk assess. And after a conversation, helping them to decide what is best for them. And how's that going for you?
Yeah. Well, it's kind of interesting. We talked about this earlier, and I brought up Herbert Benson, the physiologist at Harvard, who's written a number of books, including, it was called Timeless Healing. And in Timeless Healing, he talks about what are the characteristics of a placebo, right? What says a placebo is going to work, or what gives a placebo effect? And let's be clear, placebo effect is, in a study, the benefit you get from the belief that something's going to help you. And so like in a clinical study, the fear is we got to make sure that that belief doesn't influence outcomes. So we have a control group, the group who didn't get it. They got a placebo instead, or they got some sort of control intervention. So we don't see this placebo effect throwing off our double-blind, placebo-controlled, randomized clinical trial design, right? But, at the end of the day, the elements of what leads to that belief, according to Benson and the work that he did, was number one, the patient has to trust the practitioner. Number two, the practitioner has to trust the patient. And number three, the practitioner actually has to trust the intervention. So, we can see right there why when doctors write for sugar pills, why they don't work. The patient may initially have trusted the doctor, but the doctor didn't trust the patient enough to give them a prescription for something that was real. Thought there was something about their behavior that I can give them a sugar pill instead of what they wanted. And number three, when the doctor writes for a sugar pill, he knows full well that it's not active. 2 out of the 3 elements are missing. And it's not surprising that even if there's an initial benefit from the taking it, that it's lost during further interactions between people.
Yeah, it's interesting. And I tried to think, have I ever written for a sugar pill? Nope, never have.
I actually did write for a placebo once.
What's interesting about it, though, is how often do you find with further conversation and gaining greater perspective with the client, the patient, in more dialogue, that you come to a better spot, a better path where the placebo question isn't even there.
Yeah. It takes time, doesn't it? And it goes back to
it does.
How you build that trust. And when I was growing up and thinking about being a physician, I had certain role models on TV of what physicians were, right?
Mm-hmm.
And I had Marcus Welby, I had Hawkeye Pierce, I had a lot of remarkable physicians, whatever the doctor's name was on Medical Center, Chad Everett, whatever his name was, the character he played. There were remarkable people. And, if you think about Marcus Welby, could any doctor care more? He only saw one patient per episode, or so it seemed. He had Consuelo.
The episode was, what was it? An hour? Was it half an hour? I don't know.
It represented several days' time, and he had James Brolin's character, the young doctor, involved. He had Consuelo involved. He had his daughter involved, and it was a team to resolve the issue around one person. It was quite remarkable that was the case. Really quite remarkable that was the case. And, it taught people, it gave people a model that doctors couldn't live up to. And when Hawkeye Pierce said something like, if they arrive here alive, they should leave here alive. Well, he was in a trauma hospital, in a military surgical hospital,
Right.
And we set expectations, and the AMA advised on all of those. They knew what they were doing. The old guys in the AMA really set the next generation up for failure, while they lined their pockets with high charges and refused to consider any sort of reform that would have been good for patients and physicians and wouldn't have put money into insurance company pockets. Obviously, I'm on a tirade today. You may have to rein me in a little bit.
Okay. You go, but I was going to say that, it's also interesting, Joe, that in the transformation of healthcare in the United States over the last number of years, the time that people are in practice in the same location has markedly dropped. Just now, it's just over 3 years. Just over 3 years in the same location.
Yeah.
In a kind of the middle of our career, we were in a small town in North Idaho, St. Mary's. There were two physicians. There were two elder physicians that were still practicing, that were in their 70s, taking care of patients in their 70s and 80s. And they had been in that town practicing for 30 to 40 years. There was that relationship. There was that understanding. There was that journeying with the patient within the community. And there were a couple other physicians that had been there over 20 years. And that is really an aberrancy compared to the average time that a primary care physician is in their practice before they change. And what you lose with that hiccuped or very shortened relationship is you lose that exact word, relationship.
Right.
Where you can, yeah.
Go ahead, Michael.
And with that losing that relationship, there's losing trust. And so where are the trusted places in our society? Less people are going to are involved in faith communities, right? Less people are involved in social organizations that really grew out of the Korean War, Vietnam War, World War II, Korean War, Vietnam War. Think of the Elks, the service organizations, Elks, Eagles, Lions. So where do we find those communities of trust? And a lot more are virtual, aren't they?
Well, they are. And the interesting thing is, there's almost seems like there's been a concerted effort to report the negatives of certain professions over time. When Walter Cronkite said something at the end of his newscast in the 1960s, the great majority of Americans trusted him.
Yeah.
We no longer trust politicians. We no longer trust reporters. We no longer trust attorneys. We no longer trust doctors. We no longer trust ministers. All of these, what at one point in time represented ethical, moral, educated voices within the smaller communities, right? Like going back to that 70-year-old physician, if he had stood up at a community meeting and said X, well, that would have had weight. And, out of that kind of trust that someone cares and someone may be right comes a sense of security that allows you to feel comfortable in your world. But, when you're not feeling secure, and again, this is me going off on one of those little paranoid notes, when you're not feeling secure, you look for other means of gratification. Perhaps you're going to buy yourself a toy or something to eat or something to drink or buy a drug. I mean, look at the number of people in this country who are addicted to opiates. And, again, people are looking for something that makes them feel safe, secure, and happy, and they're not getting it in relationships. And the danger is, that it serves some of these companies well. I heard it put forth a number of years ago that these multinational companies that own both pharmaceutical companies and food companies sell you cheap processed food and make pennies of profit on what they sell you, but they turn around and make dollars of profits on the drugs that they sell you to treat the diseases related to the processed foods, which were addicting as well. And, and you look at that, and then you look at what we grant, what makes a social media influencer successful these days is not necessarily how much right information they have. It's how they present that information, what the appearance is, what the color is of the background. When you have, online people doing A/B testing to see if this color blue versus that color blue leads more people to click through to buy something, we're being manipulated.
Yeah, the recent book Hooked talks about how we hook our society and different things, and this was being hooked on processed food. And so I think it's a very reasonable thing that we get hooked, and the information that comes before our eyes on the net is influenced by the algorithms, things that we click on. And I think going back to your comment about Walter Cronkite, it's interesting because what was his sign off? His sign off, and that's the way it is. This is Walter Cronkite. Good night. I mean, and with a definitive statement, and that's the way it is, right? There is a certain security in that definitiveness, and we all appreciate that definitiveness, no matter where we're at in life, right? And so, what are the things that give us that? Is it a peer group? Is it family? Is it the media we're looking to? And without finding or self-reflecting on what gives us the strength to make a decision, or the trust to make a decision, then we're going to have hesitancy.
Yep. I think for me, the take home, we've spent over 30 minutes identifying the problem. So for me, I think the take home is getting to know ourselves well enough to know what our priorities are and to know that we're someone special. And then once we do that, once we recognize our own specialness, that we're a unique person worthy of respect and reverence, as we start looking at others and looking for those features in others, we'll know what to trust, and we'll know who to trust. And, maybe that return will be one that kind of helps us take our next steps. You and I are in, Susan Buell and Courtney Suter are going to be doing a Facebook Live on the 24th of April, which is a Saturday, 9 a.m. Pacific Daylight Time, right here, called 90 Minutes of Recreation and Visioning. And it's an introduction to some of the techniques to get to know yourself in that way.
Yeah, looking forward to that, and that'll be a nice introduction and kind of prelude to some of the information that we're going to be going over at Harmony Hill over a couple days in June, and then followed at Feathered Pipe in Montana, July 5th, at the beginning of a multiple day event and workshop, and so that will be good.
Absolutely. Well, everyone, we hope you have a good week, and we'll catch up with you next week. Thursday, though, I have another women's health seminar at 11 a.m. and a lunch and learn, I think, on cardiovascular health topics at 12 noon Pacific time, also on Facebook Live. So thanks a lot. Take care.
All right. And that's the way it is.